Yeah, good morning, everybody, and thank you for attending this panel discussion. Our topic this morning is discovering optimal opportunities for payer-provider collaboration, with the goals of improving the exchange of information that will result in better coordination of care, reduce the burden of prior authorization, and improve patient outcomes. I'm pleased to have a panel of three experts in this area, and I want to introduce them. Dr. Eric Gracious is the Chief Medical Officer at Evicor Healthcare. He joined Evicor in 2013 and served as Evicor's Chief Medical Officer since 2019. He is responsible for the overall clinical performance and quality of the company's management solutions, as well as the development of innovative capabilities. He oversees the company's formulation and maintenance of clinical guidelines, as well as its payer and provider relations. Dr. Gracious serves as the Senior Clinical Liaison to Evicor Health Plan clients and the broader physician community. He is a board-certified pediatric hematologist-oncologist, and prior to joining Evicor, he was Associate Professor of Pediatrics at the University of Tennessee College of Medicine in Chattanooga. So, thank you, Eric, for joining us.
Thanks, Brian.
And then Dr. Andrew Hertler is the Chief Medical Officer at New Century Health. As Chief Medical Officer, he is responsible for the advancement of the company's clinical quality and value-based strategy, as well as utilization management policies and clinical thought leadership initiatives. He is a practicing board-certified oncologist and is nationally recognized as a leader in oncology clinical practice. Prior to joining New Century Health, Dr. Hertler was the Administrative Medical Director for Physician Practices at Maine General Medical Center and the Medical Director of the Harold Alphons Center for Cancer Care in Augusta, Maine.
Thank you, Brian.
Another Andrew, so it's easy for me to remember. Dr. Andrew Mellon is the Chief Medical Information Officer at SureScripts. He's focused on helping the SureScripts Network Alliance improve the patient experience with electronic prescribing and the provider workflow. Trained in internal medicine, he spent more than 2 decades working in health information technology at companies including McKesson, Red Brick Health, and most recently Spoke. Before that, Dr. Mellon led the provider engagement team at Alena Health in Minneapolis through an electronic health record implementation spanning 8 hospitals and 60 clinics, and has worked as a hospitalist in St. Paul, Minnesota for over 15 years. So pleased to have him as well. And he survived the HR implementation, which is good. I'm Brian Covino. I'm the Chief Medical Officer at Cohere Health. I'm an orthopedic surgeon. I practiced in Knoxville, Tennessee for a large independent subspecialized practice doing joint replacement surgery for about 27 years and joined Cohere Health in May of 2020. So I choose the pandemic as a jumping off point from clinical practice into the other world. So as you all know, in terms of payer-provider collaboration, I often think about the prior authorization process, and this is certainly a hot topic for everyone. We're well aware of the frustration of the provider network around this process. The now well-quoted, often quoted AMA survey in 2020, where providers said that 94% of them experienced some delay in patient care, this process. 79% said that they had a treatment that was abandoned due to the PA process. 30% said that they had a patient have a serious adverse event because of this. And interesting, and we'll talk about this as well, is 32%, or a third of the provider network, feel that the evidence-based guidelines are rarely evidence-based. As well, there's a significant burden to the provider network in terms of time spent and costs managing this process, and that's time spent away from patient care. On the legislative side, there's been a lot of activity in the last year. In December of 2020, CMS proposed a rule with a lengthy title, Reducing Provider and Patient Burden by Improving Prior Authorization Procedures, Promoting Patients' Electronic Access to Health Information. That's a mouthful. But essentially, it's intended to go into effect in 2023 and looks at requiring electronic exchange of information for this process, driving to interoperability, and reducing the burden of prior authorization. The federal government, also the legislature and Congress, has a bipartisan bill that was introduced in May of 2021. The Improving Seniors' Timely Access to Care, also hope to enact it in 2023 for Medicare Advantage patients, and it describes implementation of technology to enable real-time decisioning, eliminating outdated technology, and I think they refer to the fax machine probably, and then requiring faster times to decision. This audience in the state of Texas is no stranger to the Texas legislative effort this past year. That was introduced or actually voted on in September, whereby a physician or provider network that has a 90% approval rating for a certain treatment or procedure within the last 6 months would achieve gold card status, essentially getting automatically approved and not have to go through the review process. The other stipulation in that bill is that any peer-to-peer conversations that occur have to be with a Texas licensed physician in the same specialty. And so we'll talk on these topics as well today. I want to give you a quick overview of who we are at Cohere Health. It's a young company. We were founded in 2019, so only about 2.5 years old, following 2 years of research and development. The original concept for Cohere was actually developed by health insurance plan executives, so people like some of the people sitting in the audience today, with significant physician input. The goals of the company or of the project were to improve payer-provider collaboration, allow faster access to high-value care, and currently we're serving about 5.5 million members nationally. Our aim is to transform this prior authorization process using technology, and we've developed a digital prior auth platform which uses automation, real-time auto-determination. We've found that it's easy to use for the provider network and decreases their burden significantly. And obviously, faster access to high-value care, as we've described. The other concept is to reward the physician network and the provider network that are performing high-value care. I think as all physicians on the panel, we believe that the great majority of physicians do a good job. And so if they are, why can't we get out of their way and let's concentrate our attention on the smaller minority of provider network that needs some assistance and some education in the evidence. So in terms of some of our strategies is we've partnered with some specialty societies to use their appropriate use criteria in developing care paths in the specific areas. One of the other techniques that we use is using behavioral economic techniques by, within the platform, nudging providers to optimal services. It's basically a suggestion for an alternative treatment based on the evidence, where if they accept the treatment, it can automatically be approved. If they decide to not accept it, it'll go more to a review process. So again, trying to guide them within the platform in an automated fashion to the optimal care path. And then finally, to activate the patients and the providers in the process. And also integrate any care management programs that the health plans have to surface those to the provider and to the patient to increase the use of those programs. So just a little bit about, and finally, results. So we've been at this for about a year now, and so far the results and the benefits for the health plan have been decreased administrative expense in managing this process, incremental medical cost savings. For the provider network, it's faster times to decision and increasing provider satisfaction with the process. And obviously, most importantly, it's reducing delays in care for the patients and faster access to appropriate care. So at this point, I'm going to turn it over to Dr. Gracious from Evacor. I'll let you drive those slides. Thank you.
Great. Thanks, Brian. That was a fantastic tee-up. It sets up to where we're going to go next. So just a quick overview. I won't spend a lot of time on this, but who is Evacor? We're one of the largest medical benefit managers in the country. We cover over 100 million lives, over 100 health plan clients. We're in all 50 states. We've got 7 unique payer clients in the state of Texas, and cover north of a third of the membership in the state in some form or fashion. We're growing all the time. We have 13 separate medical benefit management products. We're looking at everything from utilization to unit cost to carve-out benefits. But as being in this business a long time, we do a lot of prior authorization. We intake, a lot of requests every day, and we're working with nearly every provider in the country in some form or fashion. And so the administrative burden's real for us as well. And part of this is, how did we get here? So let's talk about why it exists in the first place. This started because evidence started to change more quickly, and gaps were appearing in care, and people weren't always following evidence. Costs were spiraling out of control as a result of waste and abuse, so payers started saying, hey, before I write a check for this, I want to make sure the patient really needs it. And as that was the only channel that we had for a long time. Anytime we needed a new lever of control, which with the escalating entry points of market pricing, it seems like everything that comes to market needs to go into prior auth. We passed a tipping point a couple of years ago in terms of how many services are under prior auth. And it's a tremendous strain for the providers and for the plans and for everybody involved in it. But why are we doing it and what's the gap? Okay, so what I hear all the time is doctors are doing it right. They're getting it right, they're smart, we need to stay out of their way. And if I replace the word doing it right with intending to do it right, totally agree. I know very few physicians out there who are dishonest and trying to they're in it for the money. They're genuinely trying to do good. They're genuinely trying to stay current. But the pace of innovation is moving too quickly. And blind spots creep into your knowledge, and those blind spots can hurt your patients. And so we need systems in place to be a safety net to catch those blind spots as they're occurring. Medical knowledge in 2020 doubled every 73 days. Okay. So any doctor that says, I'm keeping up, that in and of itself is a blind spot. And the problem is my blind spots are different than Andy's or Brian's and anyone else, and they're moving. When I first got into the business, my first job was to write some evidence-based guidelines and leveraging professional society input and things. And I thought this was going to be so easy because it was a topic I did every day. And I was just like the data. 70% or so of what I knew to be right was spot on. And the other 30% that I knew to be right was just not. And blind spots had crept in. And when I went to find references to back up what I was doing, they just weren't there. So just to put a couple of factoids on this. Okay, so NCCN is the National Comprehensive Cancer Network. Okay, they write standard of care guidelines for virtually every cancer type. They're widely accepted by every stakeholder group. It has its limitations, and I think Andy Hertler is going to talk about how they fill some of those gaps going through that. But just to put a number on it, just for that one professional society, they updated their guidelines more than 170 times in 2019. Across 54 cancer types. On top of that, the FDA approved 18 new cancer drugs and expanded use for 28 others. And so there, that just that's just for one area, how quickly that's moving. And then if you remember several years ago, the professional societies tried to solve some of this problem for us. And they said, okay, there's this big initiative called Choosing Wisely, and we're gonna identify 5 low-value services that our members need to stop doing. We all agree they need to stop doing. It was this huge effort. The information's still out there. It was all 2013, 2014, 2015. Really good stuff that we aligned to, but the uptake just hasn't been there. So the example on the screen, it's been in a couple of different ones, is don't use PET-CT for follow-up of patients who don't have disease because the false positive rate is very high. But despite that, 40% of physicians are still doing it. I mean, so the people I'm supposed to trust saying so doesn't get it done. So that's why we're here, but we can't stay where we are. We can't do prior auth the way we've always been. So we have got to focus on evolving it. So how do we retain the support and increase support for the blind spots that are only going to increase as the speed of innovation changes? But how do we do that in a more automated way? How do we identify the times where that physician is getting it right, which, shooting from the hip, almost every physician in the country is getting it right at least 70% of the time. So how do we identify those quickly in an automated fashion and get out of their way, but be there when needed? And so we're going through some steps, and I won't go too far down the rabbit hole here. We're deploying some artificial intelligence, natural language processing, and machine learning to do just that, to curate data sets, based on previous ordering behavior to identify the likelihood that something's happening right the first time, get out of the way. Can we stop asking providers so many questions and just let them upload things? Can we take that burden on? And so we're able to shorten things down. So we're at a point now, we operate at a large scale, as I said, and we would collapse under our own weight if we didn't have automation. And so, the more than 70% of our authorizations are approved immediately. More than 90% of our authorization requests are processed in under 24 hours. That's still not ideal. We still have some gaps in there. So, we have more to do, and it's going to require input from everybody. There's, Andrew Mellon's going to talk some about the interoperability, and some of the challenges associated with that, because it seems pretty simple. Just get the information out of that system into this one. But the wiring behind the scenes to do that is costly and time consuming. And so we need to think about different ways to engage, different relationships to be in contractually, different ways to share information, different ways to share accountability. And we have this tremendous opportunity to pilot in different areas. And so I'm going to stop there and pass it over to Andrew. But just to say, we've gotten where we are for good reason, but we need to change, and we're excited about the opportunity.
Let me talk to you briefly about New Century Health. We are a specialty care management company that works in only two specialties, cardiology and oncology. And the unique aspect of New Century Health is taking on the risk of the cost of the care in a capitated manner, and we've been doing that for the 20 years of our existence. I'm going to talk to you briefly today about the work we're doing to redefine oncology cost and clinical management. Let me walk you briefly through a 20-year history of trying to create value in oncology. The initial model was a traditional prior authorization process. The limitations of this, it tends to emphasize cost over quality, though it did create savings. It really lacked specialty depth, and it was very abrasive to the providers, what with phone calls, faxing of documents, and not at all appreciated. I never appreciated myself as a clinician. Over the last 10 years, with the emergence of web-based clinical pathways, we were able to incorporate the decision support, which Eric just spoke of, into the prior authorization process, and also provide instantaneous automated authorizations, which did decrease the burden significantly. We have a new opportunity now, however, with the advent of alternative payment models. There's an opportunity to share risk in a collaborative fashion with the provider using these same tools, decision support, and providing them with data to move forward in a way which has much less of a dependence upon prior authorization. When one looks at cancer care, there are really three initiatives to create value. The first is the drug spend itself. The drugs in oncology account for between 55 and 60% of the spend. And the management approach we take to this is decision support, evidence-based pathways, trying to guide the clinician to the highest value choice. The second area is hospitalizations. Approximately 50% of the hospitalizations of patients receiving chemotherapy are preventable. So can we proactively identify these patients and intervene before they ever show up in the hospital? And the last is end-of-life spend. A significant proportion of the cancer care dollar is spent during the last month of life. We feel the solution to this lies in providing palliative care, not as an alternative to whatever chemotherapy they're receiving, but as an adjunct. So first, let's talk about addressing the drug spend through clinical pathways, which I've mentioned. And when we look at clinical pathways, what we're trying to provide is what the patient wants. And in cancer care, what the patient wants is really quite simple. They want to live longer, and they want to live better. With the help of our scientific advisory board, which is made up of oncologists, academic, community-based from across the country, we try to wade our way through the NCCN guidelines, which, as Eric mentioned, are constantly changing, very complex, and which are the best choices. When one looks at any given clinical situation, you may see here I have, if you look at the middle of this diagram, 7 different chemotherapy treatment plans, what we call regimens, but there can be 15, there can be 20. They are not all equal. No one would believe they're all equal. We drill down into the original data and we try to determine which of these is going to make the patient live longer, which actually shows an overall survival advantage. With the accelerated approvals we have hitting the market today, those by definition have not shown an overall survival advantage. They have surrogate endpoints, something that they think indicates it will lead to patients living longer. But in actuality, when the data actually comes in, less than 50% of them will actually improve survival. So which have been shown to increase overall survival. Then we look at toxicity. And we're particularly concerned about those that will impact the quality of life, put people in the hospital, or lead to a permanent disability. And you can see we've knocked regimens out. They don't work as well. They're more toxic. And as a last step, we can look at cost. Everything else looking equal, let's look at cost. On the far right, that's a year of data, cost of episodes of care for 3 cancers: breast cancer, lung cancer, colorectal cancer. The green is patients treated on our pathways, and the blue is patients not. So the cost savings flow out of higher quality, and that's what really attracted me to this whole approach to begin with, that you can get better quality at a lower cost. These pathways can be used in numerous ways. In the middle of this complex graph here, there's a more traditional prior auth model where if they choose the pathway, it's instantaneously authorized. If they don't, it falls through review in a more conventional prior authorization process. But there's other ways to use this when the provider shares risk. You can use the automated assessment. We can immediately score it for being on pathway or off pathway and just feed it back to the provider. And they can then police themselves. The leader of the group can go to someone and say, why are you doing this? Interestingly, a couple of practices have come back to us and said, you know, we'd really rather you do this rather than us. Providers don't like policing themselves all the time. How about hospital costs, inpatient admissions that can be prevented? This is some data on Medicare patients. 56% of Medicare patients receiving chemotherapy are going to end up in the emergency room, and that's a problem. It's a problem because emergency room doctors are not trained in cancer care. They don't have the protocols, they don't have the training, and cancer patients tend to look sick. Even though they may not have their hair, they're thin, they haven't eaten as well, they get admitted. In fact, they get admitted 63% of the time. When we've looked back at those admissions, 50% or more of the time, those could have been prevented. There were steps that could have been taken before they ever showed up in the ER that would have prevented that admission. And this is important because the average cost of an admission of a patient receiving chemotherapy is $22,000. What we've done is taken the data we collect through our pathway tool, and using a linear regression algorithm, we can categorize patients by the chemotherapy they're going to receive, by their baseline characteristics, by how advanced their tumor is. What is your risk, high, intermediate, or low? And in our experience, 15% of the patients account for 60% of the ED visits and admissions. So we can flag these. We can feed them back to the practice, and they can take whatever steps might prevent that hospitalization, maybe change the chemotherapy regimen, or something as simple as have a visit with them virtually or in person 24 to 48 hours after the chemotherapy. We also can provide the nurses with their own pathways, triage pathways. So when patients call in with symptoms or side effects, it walks them through a standardized series of questions, and it scores the symptom severity, and it makes a recommendation. Treat the patient at home, bring them into the office, or if they need to go to the emergency department, get them to the emergency department. These pathways also offer educational materials and make targeted recommendations for interventions. Finally, palliative care. Several studies have found that patients who are engaged with palliative care, even if they're still receiving chemotherapy, can save upwards to $6,000 to $8,000 per patient. One study estimated that if palliative care enrollment increased just by 2% annually over 5 years, that would save $2.7 billion across the country. 5% increase over 5 years would save $6.8 billion. We use the data we get through our pathways, similar to predicting who's going to go in the hospital, who has the greatest need of palliative care, and then we can work with the physician to coordinate a referral to a palliative care specialist. We also, through the partnership with Vital Decisions, who joined New Century Health this year, engage the patient up front to take into account their values and wishes with regards to their medical care, and can communicate this to the physician as well in the form of advanced care planning. So our vision for the future is one where we share risk and collaborate with physicians and use our tools to optimize high-value drug utilization, decrease preventable hospitalizations, and institute palliative care when appropriate. And as a quick case study of this kind of approach, we've taken it some practices who are participating in the oncology care model, CMS's oncology care model. This is one practice, Cancer Care Specialists of Illinois. And they partnered with us, and during the course of that partnership, were able to decrease their drug spend 13.5% versus the OCM median. During that same period, their pathway adherence went up from 69% to 81%. And this is very similar to the kind of results we'll see with our more conventional prior authorization model, but with no prior authorization, completely voluntary, though with a very motivated practice who took two-sided risk in the oncology care model. They could not only gain money, they could have to pay back to CMS. So, thank you.
All right, thank you. So many of you know SureScripts as an e-prescribing network. And SureScripts did help bring e-prescribing to the United States. It's one of the great success stories of healthcare interoperability, to the tune of 1.9 billion electronic prescriptions last year flowed through the SureScripts network. And we're connected to virtually every electronic health record, every pharmacy, and every pharmacy benefit manager. But what we've done is we've taken what we've learned with e-prescribing interoperability and expanded that far beyond the pharmacies, pharmacy benefit managers, and electronic health records. We now support many other network members, or we call it the SureScripts Network Alliance, and includes especially pharmacies, long-term care, and more recently, health plans. We've also expanded far beyond the e-prescribing to things like clinical data and messaging, prior authorization, real-time pricing information for providers. So SureScripts now has a master patient index of 324 million patients, supporting about 2 million healthcare professionals. And with all those clinical transactions, about 17 billion clinical transactions flowed through the SureScripts network last year. So as we're supporting health plans, I want to talk about just briefly the 3 areas that we're working on today. The first one is helping those patients, helping the provider align on the pharmacy benefits. SureScripts for 20 years has been bringing formulary information to the point of care. And as a physician, I remember when I trained and learned a long time before EHRs, it was about 7 words on a piece of paper, and that was my prescription. Pretty easy. If you ever looked at an EHR prescribing page, it's much more complicated today because we have to inform providers not only of more clinical information, but of the patient's benefit information. So some of the new things we're doing, bringing that health plan information, bringing the medication information to the point of care, is real-time pricing information. So that patient and provider can see on the screen that patient's specific out-of-pocket cost in the EHR before it's sent to the pharmacy, as well as less expensive alternatives with those prices. And when that prescription does need a prior authorization, it can start the whole prior auth workflow in the EHR, native in that EHR's function, using industry standards, pre-filling a lot of the information out for the provider, reducing that burden, and often getting a result back in minutes on the medications. So a big part of what we're doing is helping that provider and patient align on the pharmacy benefits. The next thing we're doing is bringing more clinical data to health plans. So today, in a health system or many practices, if you walk in as a hospitalist, and when I took care of patients, I took care of patients on nights and weekends. That patient would come to me, and I would have 0 data. They didn't come from anywhere. Well, today, if you walk into many health systems, that literally in their EHR, they go and they look for outside records. Through SureScripts, they're searching across the country for all those patient encounters. And for the majority of them, where that EHR is connected to a network called Care Equality, we're actually helping retrieve that data. So that provider is seeing data, whether it was in California, Florida, New York, when they show up to me as a patient, as a hospitalist in Minnesota, without any work on the provider to try, or patient to try to locate that. So we're bringing that capability to health plans now as they're doing care management, so they're able to see that patient information no matter where the patients had their care. On top of that, we're bringing forward care events. So we have some unique insights about when a patient shows up at a practice or even before they show up. And that way, as a health plan, as you're managing those patients, you can proactively intervene and know about something that's about to happen or has happened with the patient very shortly after that event. So that's the second thing we're doing with Health Plan is bringing that clinical information from across the country, whether it's summaries or information from the EHR or those care events, to your care management solutions. And the third thing we're doing is improving communications and bringing some messaging from health plans to providers. Now, I've been to practices, and I was one a couple of years ago, and I had the opportunity to just look at what was on their fax machine, right? Which is the way a lot of healthcare communication happens today, that universal inbox. And there was lab results, hospital discharge summary, a menu from the restaurant down the street, a clinical lab result, a used car. There was like a used car special thing. I mean, it's crazy, right? I mean, that is such an antiquated way to communicate to providers. And so today, there's capabilities in most EHRs to accept secure messages directly to that provider with patient context. That's largely been used for referrals and other ways. Now we've extended that so you can communicate from payers, gaps in care, other kinds of information securely into that provider's workflow, into their EHR. So you can have that secure messaging in their workflow, a part of the patient chart, and honestly, we can get rid of those faxes. So I just want to spend a moment, this talk was about payer-provider collaboration. I've spent 20 years thinking about and working on technology at the point of care. At SureScripts, we bring a lot of that information to the point of care, and I just want to bring some perspectives on how you can be successful. What does it take to improve that payer-provider collaboration, especially getting into that provider, that not just having the technology, but driving adoption. So I'm going to break these 6 things down into 3 buckets. The first bucket is around making sure the provider trusts the data. It is so important that the provider has a consistent experience, that they trust the data, so every time they're looking at it, so they're seeing it every time, and they're trusting it. And I'll give you a couple examples. We've worked with health plans that say, I only want to turn on maybe that pricing information or prior auth for providers for some of my plans. Maybe it's cost reasons, maybe they don't think it's going to have value. And I will tell you from talking to providers, probably the number one thing they tell me, actually the number one thing they tell me is, I just want to see this consistently every single time. If it's like a roulette wheel where sometimes they see it, sometimes they don't, they just lose trust, they give up, they stop using it. Consistent data is really important in complete coverage. The other key part is what we see is a lot of the internal systems, internal data gets exposed to the providers through these services. And I suspect I know many organizations have never looked at the data, their internal information, through the lens of what if I'm doing this at the point of care with a prescriber. So what do we see? We see this sort of poor quality experiences for the provider. A great example of this is around prior authorization. In order for prior authorization to be kicked off, your systems have to flag it appropriately immediately in that first set of data. And when that doesn't happen, it goes to the pharmacy, and then the pharmacy sends a retrospective or a later prior auth back to the provider. And that drives a prescriber crazy. They're like, the system doesn't work. Why isn't it telling me I need a prior auth when I'm writing it for the patient? I would have changed my med. I might have done something different. So as you work with these systems, as you bring the information to the point of care, maintaining that trust, having high quality information, having complete coverage is absolutely essential. The second thing is workflow. I've seen many companies say, we'll just put in another portal. We will make a little application that's launched in the EHR. And they almost always don't succeed, with some exceptions. We strongly believe that these tools, these solutions, these decision support processes have to be right in the provider's workflow as they're doing the work. So when they're seeing the pricing information, it's not 3 screens later, but it's as they put that drug in the system, it pops up the exact price. No extra buttons to click, it's just there. When they need to do a prior authorization, it's immediately after they submit the medication. It just does it automatically and takes them or their office staff to the next screen. The other thing with these solutions is we think all the time that it's a prescriber's problem. The prescriber's got to do it. But if you go to any practice, that prescriber, that physician, the provider has this, as we all know, a support staff that actually does most of the work. We spend a lot of our time taking these tools, working with our health plans, helping them understand it's not just getting the provider to change, but it's getting their office staff to change their workflows and their processes. We see prior authorization as a great example where we work with health systems, we work with practices where they bring in this kind of solution then within EHR prior auth and go from every sort of practice doing it on their own in a different variable way to now they can centralize these processes and do it far more efficient way. So thinking about those workflows, not just in the EHR, but across the practice or organization is critical with these payer-provider collaborations. And the third thing is just awareness. I mean, if I talk to my friends, my physician friends, they are bombarded with things they have to know today. There is a new payer regulation. The health system has a new policy. There's a new feature in the EHR. It's on and on and on, and they can't remember it. In fact, probably 95% of the time, they don't even read the stuff you send to them. We spend a lot of our time driving awareness and making those messages one that the providers care about. I always think when I'm talking to a provider about adoption, the first thought that goes through my head is, what's in it for me the provider? How am I going to frame my conversation? How am I going to talk to them? It's not about, that me may be about the patient and how they care for the patient, but that me may be about the time, that me may be about my economics, that me may be, all kinds of other things. I have some crazy stories around, providers telling me, the me for using this technology was, this is one of my favorite stories, was I'll only use the EHR if you set it up in a closet far away from where the patient care is in the hospital, because the guy was an orthopedic surgeon. He went to round at 5 in the morning before any family was there and get out of the unit as fast as possible so he didn't have to talk to anybody. So, but then once we got him that, he was happy. So understanding how to frame these tools, frame these conversations in a way for them. So pricing, maybe the provider doesn't think it's their job to talk about price with the patient. I disagree with that. But you tell them, we'll cut back on your phone calls from the pharmacies and to redo your work later. They get it. They see that value. So as we work with the health plans and we think about how we deploy these services, how we drive adoption, it's a multi-channel support or helping the providers understand these tools through multiple different channels and really framing the conversations in ways that resonate with the providers, helping them sort of say, yeah, I should pay attention to this, I should adopt this, I need to invest my time to change the way I do things today to adopt these tools.
Great. Thank you all. I want to leave some time for some questions from the audience, but there were a couple of questions that came in from attendees ahead of time. And so I'll pick on Eric first. Keynote speaker yesterday, Dr. Marty McCary, talked about value. And one of the elements of value is quality. He said that typically we measure quality after a treatment takes place. He said that's really not quality, it's consequences of treatment. That's right. Quality should be what's the appropriateness of that treatment in the first place. He also talked about how if you wait to have 3 level 1 randomized controlled trials to get evidence, you're missing the boat because there's a lot of that evidence is already there. And you talked about the frustration of trying to write guidelines. Thoughts on where we go with guideline development and what is evidence-based?
No, it's a great question, and it's been a part of my everyday life for the last, forever. It's complicated. Not to put too fine a point on it, there's a ton of information out there. I mean, you have some good leading indicators. I mentioned NCCN earlier. That's a specialty area that's really taken ownership of establishing standard of care guidelines. So then it's a matter of figuring out where those gaps are. So there's a little less to do on that. But then you've got areas that it's completely random, or even more fun when you have specialty societies with competing self-interest issuing contradictory recommendations. And so we have to sort through all that and figure out what's really the right thing. And so we've got a whole team of people that's all that they do. They're just reviewing and curating guidelines and working with our physician SMEs and external SMEs and our advisory boards to make sure that it all stays current. And we're even having to adapt our processes. We have some of our more stable programs that we've been able to get away with updating guidelines once a year, which is what we're required to do from an accreditation standpoint. And that just doesn't cut it anymore. You need to be able to make changes in the moment as practice changes. So, and having a framework to do that is critical. So having some formality around to Brian's point, what constitutes high quality evidence? There's grading. So I mentioned NCCN. It may surprise, and people would say that's the standard of care. Everybody agrees with it. And Andy highlighted something in there that not a lot of people realize. But if you look at a formal system for the objective grading of evidence, saying what's the strength of the scientific methodology or approach behind that recommendation, there's a pretty wide range. There's 5 kind of major categories. Everything from the fully randomized, double-blinded, prospective, randomized controlled trial with thousands and thousands of patients that you only get about 3 of in your lifetime, to, well, this person's a pretty knowledgeable guy, and he said that's a good thing to do, and then everything in the middle. NCCN's specific recommendations run that whole gamut. So even within a widely adopted standard of care, the strength of the evidence for various specific guidelines is all over the place. And so sometimes that's because they didn't do enough research or cite enough references, and sometimes that's just because it's a rare condition, and that's all the evidence there is. So I'll leverage my background in pediatric oncology, okay, which is 2% of all cancer cases, in the world. So you're starting from a pretty small number to begin with. And you've got pretty strong evidence for the first round of treatment. You've got good, high quality studies defining your standards. Once the cancer starts to come back, every time that happens, kids generally can tolerate multiple bites at the apple to a greater degree than adults can. And the evidence gets increasingly thin out there. So we have to apply some common sense and we have to apply a filter that understands what's the available possible evidence when considering the strength of a particular piece for a particular area. So for example, we'll require relatively strong evidence for a first-line treatment for cancer because it's really common and there's lots of folks. But the fourth time around, the number of patients who've actually been tested in a clinical trial and reported on in that setting gets very, very small. So the quality of the evidence that's available may be less, but it still may be the best available. So there's a little bit of nuance in there, but I think it is important. It's part of our core brand and part of my personal belief that if we're sitting in a place, any of us up here, saying, hey, here's the right way to do it, we need to have something more than our say-so. We need to have quality evidence that's recommended and acknowledged by others, and we need to be transparent about where it is and where it's coming from. And to my earlier point on the pace of innovation, just because we've created a guideline doesn't mean it's fixed. We have blind spots just as well, and we rely on those interactions with providers and other experts to say, hey, you missed something here, or hey, the evidence has shifted, did you know? And so there's a dynamic element to our guidelines that allows us to be as current as possible. But great question.
Yeah, great. For Dr. Hertler, I think you touched on this in your talk already, but wanted to bring it up again because it was a question from an attendee. In terms of preventing hospitalizations and introducing palliative care, is there a role for the health plan or vendor in directly approaching the patient?
Yes, I spoke briefly about that and vital decisions. And as a provider, I think we need to be very careful about that. I think there is, in fact, a role, but it's absolutely critical that there be communication with the provider and that you all be on the same page. I've had the experience myself when I was gone for a weekend and a partner covered me with a patient, and I'd come in, my patient would be furious with me because they heard a different story. I wasn't leveling with them. I'd say, well, what did you hear? And they'd tell me, and it was exactly the same thing I'd been saying, but it was painted in slightly different words. And mixed messages to patients, especially those with life-threatening illnesses, can be devastating, and it's very upsetting to the patient. So I do think there is a role for working with patients to determine their wishes and their desires with regard to medical care, but communicating those to the physicians and be certain that that communication is bilateral, so both sides are seeing all of the information to avoid exactly that situation. Oncologists like to say, well, we do palliative care, we do advanced care planning, but the bottom line, it's not our primary orientation. We are trained to treat cancers. We are trained to give chemotherapy. We are trained to manage the complications of chemotherapy. But we aren't necessarily always the best people in the world to have conversations about advanced care planning, about end-of-life issues. And so I think there is a role for other physicians, for palliative care specialists to be involved, and there is a role for payers to participate in that, but there has to be communication.
Agreed.
Yeah, if I could piggyback on that, I totally agree. When it's something we've contended with, because we get asked a lot, can you support palliative care services? And Evacor is now part of the Evernorth brand of companies, and it's expanded our service offerings, and we actually have a palliative care, in-home palliative care offering available through Evernorth. But at the same time, we got to be really smart about and careful about that, because the last thing we want to do is disrupt the communication that's going on between the treating physician and the patient. So, that's all set up today for us. It's in a triangular model where the provider's a part of that communication stream. And there's ways we could spend the whole time talking about palliative care, and it's misnomer and attachment to hospice and why that's happened. But there's a way, I think, for health plans and care managers and others to help fill that communication bridge, because the data is pretty clear that most oncologists are willing and able and interested in talking to their patients about palliative care. And most patients are willing and able and interested in talking to their oncologist about it, but both sides are not great at initiating the conversation. So there's a role in there about asking targeted questions without being so overt to help empower the patient to trigger those conversations at a time that's not attached to a crisis, and they're more likely to be productive.
So for Dr. Mellon, I hate to put you on the hot seat, but we are at the Texas Association of Health Plans meeting, so I have to ask you how our industry is going to manage mandatory gold card bills such as we passed in the state.
Well, I'm going to not answer your question directly, because at SureScripts, we are not the prior auth generators. We are, we support the network, what the payers do. We support what the pharmacy benefit managers do. So, if they create a way to, take the data that we provide and gold card the provider, we'll support that. But we're neutral. So we take that. We'll do what the payers ask us to do. We're not creating the rules.
As well.
Yeah, I'll jump in briefly, and obviously I can't see the future, but my concern is that in some ways it may be a step backwards. And the reason I say that is if there's not prior authorization, then you're going to be looking at claims on the back end. And does this claim meet medical necessity? Claims information is very scant. It doesn't tell you much clinically about the patient, so what's going to happen? They're going to ask for information, and they're going to ask for pieces of the chart. And that horrible fax machine, I agree. If we could destroy fax machines, axe the fax, I would. But I worry that the administrative burden that we're hoping goes away will not. The other thing very interesting that I've heard from oncology practices, the cost of these drugs is fantastic. I mean, it can be $30,000 a month. And the practice is laying out that money. It's on their accounts receivable. And I've had practices come to me and say, I'm uncomfortable with not having prior authorization because I need to get paid. I mean, I've got 4 physicians, we're carrying this money. We need to know we're getting paid. So we will see how it develops, but I think, and obviously this panel has, I think, very similar views, but believe in using electronic information, integrating with EMRs, and prospectively determining that it's the best care for the patient and that it's going to be covered, and that the information overload is so much. No individual physician can keep this all top of mind. And they really need this decision support up front. So I'm very sympathetic to the effort. I'm not convinced it's going to solve the problem.
Yeah, and I guess I'll back clean up here on this one. The short answer is, Brian, on 1/1, we're going to be complying with the law. We have no choice. That's what we will be doing. It's a data management exercise, and largely, and it's, frankly, I tend to agree with Andy. I think this particular piece of legislation, in an attempt to help with the problem that's there of admin burden, was kind of rushed through toward the end of the session. and it didn't get a chance to go through the stakeholdering process along the way that would have added the content to this law to make it actually functional and operational and really start to solve some of the problems. So partly because of the way it went through, there's just a lot of gaps that it now falls to the Texas Department of Insurance to fill in operationalization. So I think on 1/1, you're going to have a lot of health plans kind of sitting there making their best guess, but kind of holding out unless we get really clear rulemaking before then. Just one really tactical example, once a gold card is granted, you can look back every 6 months to decide whether they get to keep their gold card or whether you can take it away. So they said you can do it every 6 months, but then the legislators wrote, and you can only do that in January and June, which are not 6 months apart. Okay, so just to give you an idea of where that particular piece is, but there are good things in there. I tend to agree with Andy on this, that one of our programs actually created in its current form because one of the payers was looking at things post-service and the providers were asking for what they call predeterminations, which are essentially voluntary prior authorization. It's, I'm not going to give this service to my patient until I know I'm getting paid. And they were getting predetermination requests on like 15% of their claims, and they weren't built to do it. So they turned on a light touch prior auth program. It's more of a decision support algorithm. So I think that's still going to be there. I think it's going to be really hard for providers to understand even when they're gold carded, because remember, these providers are taking care of multiple health plans. So they're going to be independently gold carded for individual services and in specific clinical diagnoses for each health plan. And oh, by the way, only for fully insured business, not for self-insured commercial, not for government. So I think it's going to be really complicated for the providers to consume also, and the health plans. So I think we're going to have to live through a transitional period where everybody figures out how to make this work and whether this is the right approach. So again, applaud the effort to reduce the admin burden. I think this particular piece of legislation is going to create some challenges in the short term.
Great. We're at time. I appreciate the panelists' comments. We'll stick around and answer questions, but don't want to keep anybody from Taco Tuesday, which is going on in the hall. So thank you very much for attending today.
Yeah, thank you.